Hi, can I sit with you? My name is Daisy. Ano nga ulit pangalan mo? Parati kang mag-isa. Tapos, minsan nakikita ka nakatitig ka lang sa kawalan. Siguro you're finding it weird that I'm trying so hard to be friends with you.
Bakit ka ba kasi nandito?
Kailangan ko ng tulong mo.
Daisy!
Ang self-care ay isa sa pinakamabisang paraan upang pangalagaan ng ating mental health. Ang simpleng pag-exercise o pagtutok sa ating mga hobbies ay isang paraan ng self-care. Care for yourself. Bigyang oras ang sarili at mga bagay na nagbibigay sa iyo ng saya. Nagkakaroon ka na rin ba ng Zoom fatigue dahil sa meetings o di kaya ay sa online class? Huwag kalimutang magpahinga. Importanteng maglaan ng break at ipahinga ang utak. Maglaro muna ng paboritong games. Malaking tulong ang breathing exercises sa pagpapakalma at para maibsan ang ating pakiramdam. Matuto ring mag-set ng boundaries para sa iyong work-life balance. Matutong respeto ang work boundaries ng iyong mga katrabaho. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas. Dahil sa pandemya ang ating kinakaharap, hindi mapigilan na tayo ay mapalayo sa ating mga mahal sa buhay. Ngunit hindi dapat maging hadlang ang distansya upang tayo ay mag-hashtag care for others. Nakumusta mo na ba sina lolo at lola this week? How about sina mama at papa? Mga kapatid, kaklase? Kung hindi pa, ang isang simpleng kumusta sa pamamagitan ng video or voice calls o text messages ay tiyak na makatutulong sa kanilang mental well-being. Care for others, ang isang malakas na support system, ay nakakatulong rin sa pagpapabuti ng ating mental health. Kung ikaw o sino man sa iyong kakilala ang nangangailangan na makipag-usap sa isang mental health professional, tumawag lamang sa mga numerong ito mula sa National Center for Mental Health. Ito ay libre lamang at kahit sino ay pwedeng tumawag. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas. Alam mo na ba? Ang mental health ay isang mahalagang bahagi ng ating pangkabuuang kalusugan. Walang health kung walang mental health. Ayon nga sa World Health Organization, mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. Ang mental health ay mahalaga sa ating pangkabuuan at individual na abilidad magtrabaho, mag-isip, makaramdam at mabuhay. Kaya naman ngayong panahon ng pandemya, huwag kalimutang pangalagaan ang ating mental health tulad ng pag-aalaga natin sa ating physical health. Ang self-care ay isa sa pinakamabisang paraan upang pangalagaan ang ating mental health. Ang simpleng pag-exercise o pagtutok sa ating mga hobbies ay isang paraan ng self-care. Care for yourself. Bigyang oras ang sarili at mga bagay na nagbibigay sa iyo ng saya. Nagkakaroon ka na rin ba ng Zoom fatigue dahil sa meetings o di kaya ay sa online class? Huwag kalimutang magpahinga. Importanteng maglaan ng break at ipahinga ang utak. Maglaro muna ng paboritong games. Malaking tulong ang breathing exercises sa pagpapakalma at para maibsan ang ating pakiramdam. Matuto ring mag-set ng boundaries para sa iyong work-life balance. Matutong irespeto ang work boundaries ng iyong mga katrabaho. Dahil sa pandemya ang ating kinakaharap, hindi mapigilan na tayo ay mapalayo sa ating mga mahal sa buhay. Ngunit hindi dapat maging hadlang ang distansya upang tayo ay mag-hashtag care for others. Kumusta mo na ba sina lolo at lola this week? How about sina mama at papa? Mga kapatid, kaklase? Kung hindi pa, ang isang simpleng kumusta sa pamamagitan ng video or voice calls o text messages ay tiyak na makatutulong sa kanilang mental well-being. Care for others, ang isang malakas na support system, ay nakakatulong rin sa pagpapabuti ng ating mental health. Kung ikaw o sino man sa iyong kakilala ang nangangailangan na makipag-usap sa isang mental health professional, tumawag lamang sa mga numerong ito mula sa National Center for Mental Health. Ito ay libre lamang at kahit sino ay pwedeng tumawag. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas.
Hi, can I sit with you? My name is Daisy.
Ano nga ulit pangalan mo?
Parati kang mag-isa. Tapos, minsan nakikita ka nakatitig ka lang sa kawalan. Siguro you're finding it weird that I'm trying so hard to be friends with you.
Bakit ka ba kasi nandito?
Kailangan ko ng tulong mo.
Casey!
Hi, can I sit with you? My name is Daisy.
Ano nga ulit pangalan mo?
Parati kang mag-isa. Tapos, minsan nakikita ka nakatitig ka lang sa kawalan. Siguro you're finding it weird that I'm trying so hard to be friends with you.
Bakit ka ba kasi nandito?
Kailangan ko ng tulong mo.
Casey!
Ang self-care ay isa sa pinakamabisang paraan upang pangalagaan ng ating mental health. Ang simpleng pag-exercise o pagtutok sa ating mga hobbies ay isang paraan ng self-care. Care for yourself. Bigyang oras ang sarili at mga bagay na nagbibigay sa iyo ng saya. Nagkakaroon ka na rin ba ng Zoom fatigue dahil sa meetings o di kaya ay sa online class? Huwag kalimutang magpahinga. Importanteng maglaan ng break at ipahinga ang utak. Maglaro muna ng paboritong games. Malaking tulong ang breathing exercises sa pagpapakalma at para maibsan ang ating pakiramdam. Matuto ring mag-set ng boundaries para sa iyong work-life balance. Matutong respeto ang work boundaries ng iyong mga katrabaho. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas. Dahil sa pandemya ang ating kinakaharap, hindi mapigilan na tayo ay mapalayo sa ating mga mahal sa buhay. Ngunit hindi dapat maging hadlang ang distansya upang tayo ay mag-hashtag care for others. Nakumusta mo na ba sina lolo at lola this week? How about sina mama at papa? Mga kapatid, kaklase? Kung hindi pa, ang isang simpleng kumusta sa pamamagitan ng video or voice calls o text messages ay tiyak na makatutulong sa kanilang mental well-being. Care for others, ang isang malakas na support system ay nakakatulong rin sa pagpapabuti ng ating mental health. Kung ikaw, Kung sino man sa iyong kakilala ang nangangailangan na makipag-usap sa isang mental health professional, tumawag lamang sa mga numerong ito mula sa National Center for Mental Health. Ito ay libre lamang at kahit sino ay pwedeng tumawag. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas. Alam mo na ba, ang mental health ay isang mahalagang bahagi ng ating pangkabuuang kalusugan. Walang health kung walang mental health. Ayon nga sa World Health Organization, mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. Ang mental health ay mahalaga sa ating pangkabuuan at individual na abilidad magtrabaho, mag-isip, makaramdam at mabuhay. Kaya naman ngayong panahon ng pandemya, huwag kalimutang pangalagaan ang ating mental health tulad ng pag-aalaga natin sa ating physical health. Ang self-care ay isa sa pinakamabisang paraan upang pangalagaan ang ating mental health. Ang simpleng pag-exercise o pagtutok sa ating mga hobbies ay isang paraan ng self-care. Care for yourself. Bigyang oras ang sarili at mga bagay na nagbibigay sa iyo ng saya. Nagkakaroon ka na rin ba ng Zoom fatigue dahil sa meetings o di kaya ay sa online class? Huwag kalimutang magpahinga. Importanteng maglaan ng break at ipahinga ang utak. Maglaro muna ng paboritong games. Malaking tulong ang breathing exercises sa pagpapakalma at para maibsan ang ating pakiramdam. Matuto ring mag-set ng boundaries para sa iyong work-life balance. Matutong irespeto ang work boundaries ng iyong mga katrabaho. Dahil sa pandemya ang ating kinakaharap, hindi mapigilan na tayo ay mapalayo sa ating mga mahal sa buhay. Ngunit hindi dapat maging hadlang ang distansya upang tayo ay mag-hashtag care for others. Kumusta mo na ba sina lolo at lola this week? How about sina mama at papa? Mga kapatid, kaklase? Kung hindi pa, ang isang simpleng kumusta sa pamamagitan ng video or voice calls o text messages ay tiyak na makatutulong sa kanilang mental well-being. Care for others, ang isang malakas na support system, ay nakakatulong rin sa pagpapabuti ng ating mental health. Kung ikaw o sino man sa iyong kakilala ang nangangailangan na makipag-usap sa isang mental health professional, tumawag lamang sa mga numerong ito mula sa National Center for Mental Health. Ito ay libre lamang at kahit sino ay pwedeng tumawag. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas.
sit with you? My name is Daisy. Ano nga ulit pangalan mo?
Parati kang mag-isa. Tapos, minsan nakikita ka nakatitig ka lang sa kawalan. Siguro you're finding it weird that I'm trying so hard to be friends with you.
Bakit ka ba kasi nandito?
Kailangan ko ng tulong mo.
Daisy!
Hi, can I sit with you?
My name is Daisy. Ano nga ulit pangalan mo?
Parati kang mag-isa. Tapos, minsan nakikita ka nakatitig ka lang sa kawalan. Siguro you're finding it weird that I'm trying so hard to be friends with you.
Bakit ka ba kasi nandito?
Kailangan ko ng tulong mo.
Daisy!
Ang self-care ay isa sa pinakamabisang paraan upang pangalagaan ng ating mental health. Ang simpleng pag-exercise o pagtutok sa ating mga hobbies ay isang paraan ng self-care. Care for yourself. Bigyang oras ang sarili at mga bagay na nagbibigay sa iyo ng saya. Nagkakaroon ka na rin ba ng Zoom fatigue dahil sa meetings o di kaya ay sa online class? Huwag kalimutang magpahinga. Importanteng maglaan ng break at ipahinga ang utak. Maglaro muna ng paboritong games. Malaking tulong ang breathing exercises sa pagpapakalma at para maibsan ang ating pakiramdam. Matuto ring mag-set ng boundaries para sa iyong work-life balance. Matutong respeto ang work boundaries ng iyong mga katrabaho. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas. Dahil sa pandemya ang ating kinakaharap, hindi mapigilan na tayo ay mapalayo sa ating mga mahal sa buhay. Ngunit hindi dapat maging hadlang ang distansya upang tayo ay mag-hashtag care for others. Nakumusta mo na ba sina lolo at lola this week? How about sina mama at papa? Mga kapatid, kaklase? Kung hindi pa, ang isang simpleng kumusta sa pamamagitan ng video or voice calls o text messages ay tiyak na makatutulong sa kanilang mental well-being. Care for others, ang isang malakas na support system ay nakakatulong rin sa pagpapabuti ng ating mental health. Kung ikaw o sino man sa iyong kakilala ang nangangailangan na makipag-usap sa isang mental health professional, tumawag lamang sa mga numerong ito mula sa National Center for Mental Health. Ito ay libre lamang at kahit sino ay pwedeng tumawag. Ngayong panahon ng pandemya, hindi biro ang pinagdadaanan mo, kaya naman make sure to care for yourself and care for others para sa isang healthy Pilipinas. Alam mo na ba? Ang mental health ay isang mahalagang bahagi ng ating pangkabuuang kalusugan. Walang health kung walang mental health. Ayon nga sa World Health Organization, mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. Ang mental health ay mahalaga sa ating pangkabuuan at individual na abilidad magtrabaho, mag-isip, makaramdam at mabuhay. Kaya naman ngayong panahon ng pandemya, huwag kalimutang pangalagaan ang ating mental health tulad ng pag-aalaga natin sa ating physical health. Ang self-care ay isa sa pinakamabisang paraan upang pangalagaan ang ating mental health. Ang simpleng pag-exercise o pagtutok sa ating mga hobbies ay isang paraan ng self-care.
Good morning, everyone. Please stand by. We shall start the program in 5 minutes. Thank you. Welcome to the first Philippine Mental Health Research Summit webinar, Series 3, entitled Leadership and Governance. And now let us place ourselves in the presence of the Almighty as we recite our opening prayer. This will be followed by the Philippine National Anthem.
magiliw, prayas ng silanganan, alak ng puso, sa bibig mo'y buhay. Lupang hinirang, duyan ka ng magiting, sa manlulupig, di ka pasisihin, sa dagat at bundok, sa simoy at sa langit pumabaw, may dinakang tula at awit sa paglayang minamahal, ang isap ng watawat mo'y tagumpay na nagbinigin, ang bituin at araw ng kanyang pamay magdiligid, lupa ng araw ng walhati pagsinta, buhay langit sa piling mo. Ang biligaya na pag may mga api, ang mamatay ng dahil sa'yo.
Magandang umaga sa lahat. Hello and welcome once again to our Zoom participants. I am Amadeus Pahente, Senior Health Program Officer from the Mental Health Division of the Disease Prevention and Control Bureau of the Department of Health, and I will be your host for today. Before we start, would like to remind everyone that this webinar will be streaming live on the official Facebook page of UP Telehealth. Thus, we would like to remind everyone of a few house rules. To all of our attendees, please put your questions in the Q&A chat box so we can line them up and in an organized manner for the Q&A session. For our panelists, we request that you have your video and audio feeds turned off until you are engaged. Your adherence to the house rules will ensure a minimum of disruptions and the fluid progress of our discussions. For your attendance this morning, I would also like to request our participants to accomplish the form. For us to track your attendance, the form is placed on the Zoom chat box and also flash on your screens. For the attendance, please accomplish the attendance form via the chat box and flashed on the screen. Good day again for everyone. I hope you're doing all well. Now we will have Dr. Carissa Joaquino Maligaso, the chair of the webinar series 3, to formally open today's program. Dr. Maligaso is the professor and chair in Department of Neurosciences from the College of Medicine in Philippine General Hospital, University of the Philippines, Manila. Dr. Joaquino Maligaso, you now have the virtual floor.
Good morning. Welcome to Series 3 of the 2021 Philippine Mental Health Research Summit. I am Dr. Carissa Paz Joaquino, and together with my co-chair, Dr. Carmelita Canila, we are pleased to see you online for this important aspect of mental health research. To recap, in case this is your first time to attend the summit, we have had 2 lecture series starting 2 months ago. The first series was held on June 21, 2021. The speakers talked about perspectives on mental health and mental health research. There was a lot of enthusiasm sa usaping mental health sa Pilipinas among speakers and participants alike. The second series was held on July 19, 2021. The topic was on well-being and cultural relevance. The live open forum was equally as lively as the first series. Today we are holding the third series. There will be 2 more sessions after. Series 4 will be held on September 14 and Series 5 on October 11 in time for the celebration of Mental Health Awareness Week. In Series 2, We had participants from all over the country again, that being in spite of the pandemic. The NCR had the most number of participants, reaching 201. We also had participants from the Visayas and Mindanao, and also from the Car, Barm, and Caraga. Counselors comprised 23.5% of the participants. Nearly half of the participants were psychologists. In the audience, we also had nurses and social scientists. Series 2 was well received, and participants gained knowledge and perspectives on mental health research. They were motivated to do mental health research. And opportunities and mechanisms for research support were clarified during Series 2. Finally, to summarize, here were some of the learnings during Series 2. Kapwa is so important and influential in our lives and mental health. Second, language is a mirror to culture and identity. Third, I learned of the challenges in research of mental health in terms of cultural diversity in the country. Fourth, Filipino translation of some terms commonly used by Filipinos were clarified. Fifth, effectiveness of understanding language and culture are important in mental health research. And the last would be that context matters in doing research. In addition, during the discussions, there was a clamor for capacity building for doing mental health research in the country. For Series 3, these are our objectives: to present the Philippine investment on mental health, to present an example of local government unit initiative in addressing the issue of mental health during the pandemic, to increase the awareness about the ethical issues in doing mental health research, to discuss the uses of digital technology in the delivery of services for mental health and in the enhancement of mental health research. And last, to present issues and challenges in the use of digital technology in mental health research. So without further ado, let's move forward with Series 3 and start with the lectures. Thank you.
Thank you very much, Dr. Carissa, for the review of the previous series. And also, before we proceed with our program, may we request everyone to please turn on, for the panelists to turn on their cameras, so we will have a photo opportunity.
Mads, hindi daw maka-turn ng video yung iba. Paki-enable.
Okay, ma'am. We'll inform the technical.
Oo, hindi maka-turn ng video yata si Dr. Canela.
but you have to turn on my video. Morning, everyone.
Morning, ma'am.
Hello po. Ready po tayo. Kompleto na po yung okay. Isa pa po, ma'am. Okay po. 1, 2, 3, smile. Yan po. Ulit po. Ulit po. Nandito na ako si Dr. Merlita. Okay po. Okay po. 1, 2, 3, smile. Okay na po. Thank you.
Thank you.
Thank you very much. Now, just a quick rundown of our activities this morning. At this point, we shall now begin with the technical part of our program, starting with the presentation of Dr. Jasmine Vergara. Dr. Vergara is a technical officer and national professional officer for the Mental Health and Substance Abuse of the World Health Organization Country Office, Philippines. This morning, she will be presenting the prevention and management of mental health conditions in the Philippines. Take it away, Dr. Vergara.
So, good morning. And as we know that mental health conditions such as depression, anxiety, disorders, psychosis, epilepsy, dementia, or alcohol use disorders pose a significant public health challenge in the Philippines. We all know that in 2017, the recent data or the data coming from the WHO Mental Health Atlas, the two most common mental health conditions are anxiety and depressions, which accounted for about 800,000 years of life lived with disabilities. No, during that time, reported suicide rates in the Philippines have increased over the past couple of decades, and as we also are experiencing here during the COVID-19 pandemic, the rates of the suicidal behaviors and the psychological distress are picking up, and these are something that we need to address at the onset. So I'd like to present the prevention and management of mental health conditions in the Philippines, the case for investment. This endeavor has been conducted, the case mission has been conducted early last year by the UNDP, WHO, and the United Nations Interagency Task Force on Non-Communicable Diseases. We have met with the Department of Health as co-leader for this endeavor, and we have met the different sectors, the different agencies, the NGOs, and the champions for this investment case. I'd like to also mention later that I will be presenting a part of it on the report, and the full report will be launched in October. So why do we need to invest in mental health? As we all know that mental health is an indispensable part of health. It has been defined by WHO as a state of well-being in which everyone realizes, his or her own potential, can cope with the normal stresses of life, the resilience that we have, can work productively and fruitfully, and is able to contribute to her or his own community. When we talk about mental illness, it is defined as suffering, disability or morbidity due to the mental, neurological, and substance use disorders, which are associated with the biological and psychological makeup. Are also play a role with the adverse social and conditions or environmental factors. And the investment in mental health comprises both promotion and the protection and prevention and treatment of mental health conditions. So I'd like to focus on this element. So when we talk about investing, we need to look at mental health in this definition. So what is the mental health investment case? As we all know, as earlier mentioned, mental health investment case is a quantitative analysis of the economic arguments for investing in mental health treatment, promotion, prevention, and promotion. Although it has some clear guidelines, we also did a institutional context analysis last year. We have interviewed different sectors, as mentioned, and the aims of this investment case is to demonstrate economic burden of mental health conditions such as anxiety, depression, epilepsy, psychosis, bipolar disorders, alcohol use disorders, and suicide in the Philippines, and to evidence that implementing a set of cost-effective interventions between now and the 2030 will have substantial economic rewards. And we aim to produce an advocacy piece for policymakers, people in the finance sector, or even the people who are working on the budget of allocating mental health budget for the Philippines. So in the exercise of the investment case, we have used this instrument to analyze the economic analysis. There's this One Health tool and Excel-based return of investment model developed by WHO. I would be able to expound much on this intricacies, but the One Health tool is a software designed for national strategic health planning in low and middle income countries. And the development of the tool is overseen by a group of consisting of experts from the United Nations, agencies, and development institutions. Mental health module was devised, and I will share that and where you can find it. In estimating the costs and health impacts of mental health services and interventions at the population level. This module allows estimation of number of people living with mental health conditions in country and linkage to the epidemiological status of mental health conditions to national life tables for estimation of the numbers of cases averted and healthy life years gained over time at population level. So just like to share that these are some of the instruments used during that exercise. There are 4 discrete steps to quantify the mental health intervention and its worth. There are 4 steps that we are able to look into to estimate. First is to estimate the economic burden of mental health in pesos, and then the second, we're able to estimate the impact of intervention, the number of people, percentage of reduction in mortality and productivity. Some estimates were gathered from there. Estimate the cost of intervention of some key packages or of treatment packages for mental, neurological, and substance use disorders, and quantify the return of investment of intervention ratio. For this presentation, I'll mostly focus on the first 2 parts However, the remaining results, as mentioned, will be shared in October. As we all know, that this is the economic cost of mental health in the Philippines. As you know, the table shows that the total direct and indirect cost of mental health conditions in the Philippines, as you can see here, these are the direct costs. The total health government care expenditures on mental health conditions comprise of about 2,591 million pesos. That's about 2.6 billion pesos. Yeah. And disability support payments, this were accounted for the subsidized provided by the PhilHealth, around 100 million pesos. So the total direct cost is about 2.7 billion. And for the indirect costs, as you can see, we also are estimated and computed for the absenteeism, presenteeism, and premature deaths, accounting to about 66.2 billion pesos. So if you add the direct and indirect costs, it would amount to about 68.9 billion pesos. But I'd like you all to focus that with this cost, the indirect costs, the 66.2 billion is higher even by the from the direct cost at 2.7 billion. In this slide, you can see that the graph shows that the structure of economic burden of mental health conditions in the Philippines in 2019. This was computed for the 2019. The government healthcare expenditure accounts for about 4% of the total, direct and indirect cost. The cost of interventions, absenteeism rather, is at 52%. The cost of presenteeism is at 29%, and the loss of productivity, losses due to death or premature death is at 15%. Now, this is just the tip of the iceberg for the economic burden of mental health in the Philippines. And this is the tip of the iceberg. What you can see only here are the governmental mental health care expenditures, as mentioned, and this is the visible part of the mental health burden. The losses that I mentioned to you earlier, the indirect costs, losses mainly due to the absenteeism and presenteeism, as well as the premature death due to the mental health conditions, were actually, are even greater than the direct costs. So this accounts for, can lead to enormous and untreatable losses of working age population in the workforce and economic system. So if we have limited investments in mental health, this could actually be lead to more losses. So these are the intervention coverage for mental, neurological, and substance use disorders that we were able to estimate using the One Health tool, as mentioned. So there are the intervention coverage for anxiety disorders, the psychosocial treatment and antidepressant medication for moderate to severe cases of anxiety disorders, depression, the psychosocial treatment, as well as the antidepressant depression medication for first episode and recurrent cases, the psychosis for the basic psychosocial support and antipsychotic medications, bipolar use disorder, providing the basic psychosocial treatment advice and follow-up for bipolar disorder, plus the mood stabilizing medication for epilepsy, psychosocial support, advice and follow-up, plus anti-epileptic medication for alcohol use disorders, the brief interventions and follow-up for alcohol use dependence. There were also we are also able to look into the population-based mental health interventions that may be computed on the nationwide regulatory ban for highly hazardous pesticides to prevent suicide and school-based social and emotional learning for interventions to prevent depression and anxiety in adolescents. I won't be able to give much of the numbers yet, but this is something that we have to look forward to. Again, this is the mental health burden and what we usually see and what we have to see. I'd like to emphasize here that the governmental mental health care expenditure in 2019, that expenditure plus the PhilHealth packages coverage accounted to 2.7 billion pesos. This absenteeism, presenteeism, economic losses, and the premature death were accounted for even higher as indirect costs. So would like to also emphasize that while we want to have more evidence-based cost-effective treatment packages in the Philippines, the mental health care in the systems has its strength. There's a strong mental health act that focuses on the different sectors involved in leading the mental health implementation. The Philippine Council for Mental Health, which comprises these different sectors that are mandated to cascade and the mental health policies and plans. The Department of Labor and Employment guidance for mental health in the workplace. This is also a crucial, important step in looking into the workplace and productivity, of the people. Opportunity for affordable, quality mental health care under the UHC, the Mental Health Gap Action Program. It's a package for non-specialized individuals or physicians, training for primary health care providers, the strong civil society and champions advocating for mental health, and the range of experiences in bringing mental health to the community. So we need to somehow capitalize on these trends as we see more or less movement for investment in mental health. Now, the mental health investment case offers some key recommendations to strengthen the mental health leadership and governance, invest in evidence-based, cost-effective clinical and population-based mental health interventions, include a range of mental health interventions while expanding to UHC, and increase the capacity of the healthcare workforce and the health system to provide mental health interventions. And of course, the most important, of course, here in your endeavor for this summit is to invest in mental health research and development. The full details of the report of the mental health investment case will be launched in October 2021, of course, led by the Department of Health together with the interagency task force on NCDs, the WHO, and the UNDP. We have also produced this mental health investment case guidance note, so you can see how the process of the investment case can take place. So you can actually find this at who.int, and you can search for the guidance for this. With that, we thank you, and on behalf of WHO Country Office Philippines, we thank you, and all the best for the Mental Health Research Summit.
Thank you, Dr. Vergara, for that very insightful presentation on the prevention and management of mental health conditions in the Philippines, the strengths of the current mental health care system, and the opportunities through the investment case for mental health. Next up, we have Honorable Mayor Jeronimo Treñas of Iloilo City. He's one of the champions of Republic Act 11036, otherwise known as the Mental Health Act, and has made notable efforts in localizing mental health. In this recorded presentation, Mayor Treñas will present the mental health and the COVID-19 pandemic, an LGU perspective.
The COVID-19 pandemic and all its negative impacts, including countless deaths and economic recession, has affected people's mental health and created new barriers for people who have existing mental health conditions. With our desire for a holistic approach in our fight against this pandemic, Aside from our initiatives that provide concrete solutions to poverty, food insecurity, and threats to our physical health, we have also launched various programs in the Iloilo City government in partnership with other organizations that aim to strengthen the mental health of the Ilonggos. Even before this pandemic hit us, I was already fully aware of the need for our creative and proactive responses against the fast increasing cases of mental health issues in the Philippines. And that is why, while I was still Congressman of the Lone District of Iloilo City, I co-authored Republic Act 11036, or the Mental Health Law, that aims to enhance integrated mental health services, protection of people who use said services, and the establishment of the Philippine Mental Health Council. The Department of Health reported that 1 in 5 Filipino adults has some form of a mental illness. Depression is also common among the youth, but people are afraid to seek for intervention because of the fear of being judged. With the existence of the mental health law, which was approved on June 2018, people have now a better understanding of the importance of mental health. July last year, when we partnered with Iloilo Live Events Alliance and Festive Walk Mall for a project dubbed as Ginhawa, an initiative to remind every Ilonggo to take a break and breathe amidst this very challenging time. We have also partnered with Boys and Paints and Bay Sulangpo Artist Society to aid the mental toll of the Ilonggos by painting our bridges and blank walls in the city. As we continue to fight against the unseen enemy, we also continue to find outlets that will promote the mental health and wellness of the Ilonggos. Painted walls and bridges send a message of hope to everyone that everything will soon get better. A few months ago, we also launched the Art in the Park project that aims to provide an avenue for local artists, both amateur and professional, to express themselves through painting at an outdoor setting overlooking the majestic Iloilo River. Few weeks ago, we also had the kickoff of our latest initiative to tackle the Ilonggos mental health, the Gyao, activation of multiple creative hubs in the city of Iloilo for mental health, well-being, and resilience. Dagyao is a Hiligaynon term for communal work. It is associated with mutual sharing and help that reflects the symbiotic relationship between members of a group. In principle, Dagyao is an inclusive process. Used in this context, mental health has become an inclusive governance concern that deserves a Dagyao. This is vital because breathing is an essential life process that nourishes the being through its physiological and psychological co-benefits which are needed in this period of COVID-19, with the aim of ensuring that constituents do not only survive, rather thrive. The initiative hopes the Ilonggos are able to: one, develop a culture of ginhawa to breathe; two, learn how to manage pent-up emotions arising from COVID and other stressors; reclaim their capacity to take control of their lives, to dream and to aspire; regain capacity to belong and build or enhance a sense of community, social capital, develop and strengthen social support systems, facilitate and enable learning among children, youth, adults, elderly, and persons with disability. The mitigating measure aims to avert further decline of the mental health state among the youth and the general public. The collaboration seeks to help address the mental health concerns amid the fears, pressures, anxiety, or stress resulting from the pandemic. This work will be coordinated by the City Disaster Risk Reduction Management Council via the City Disaster Risk Reduction and Management Office and with strict monitoring for compliance to health protocols. With the alarming increase of mental health illnesses today, it calls for local government units to use our creativity to come up with projects that strengthen the mental health and to ensure the mental health services are provided in primary health care facilities and hospitals. In these unstable times, the issue of mental health is very crucial. It is more than the presence or absence of mental illness. Rather, it is a crossroad between emotional, psychological, and physical well being. And it is only when we put premium on these things that we can say we are truly healthy.
Thank you very much, Mayor Treñas, for that very inspiring presentation on the unique LGU perspective on mental health and also in addressing the impact of the COVID-19 pandemic at the local level. Our third speaker is none other than Dr. Cristina Torres. Dr. Torres is a coordinator from the Forum for Ethical Review Committees in Asia and in the Western Pacific. She is also the past department chair and associate dean for academic affairs of the University of the Philippines College of Arts and Sciences, a research ethics lecturer of the University National Institutes of Health, and research ethics consultant of the Department of Health. Dr. Torres will be presenting the ethics in mental health research.
Today, I will talk about ethical issues in mental health research. What is the definition of mental health? It is more than the absence of disorder. It is the state of well being in which an individual realizes his or her own abilities, cope with the normal stresses of life, work productively, and make a contribution to community. It is determined by a range of socio-economic, biological, and environmental factors, and there is therefore a need for cost-effective public health and intersectoral strategies and interventions to promote, protect, and restore mental health. Essentially, we will be able to say that there is no health without mental health. What is mental health research? It is a very important part of mental health because mental health research saves lives, relieves significant distress, and improves the quality of life. It is therefore able to generate social and economic benefits, to develop community resilience through reduction of levels of mental ill health, stigma, and discrimination. However, mental health research is underfunded and underprioritized, and we miss the opportunities to achieve breakthroughs seen in other areas of healthcare that improve people's lives and enhance well being. This is coming from the declaration of the UK Alliance of Mental Health Research Funders issued in 2015. Clinical research in mental health is being done with the use of placebo. But it's not only in mental health that placebo is being used. So any new treatment should be able to demonstrate efficacy under controlled conditions
and safety before it is approved for clinical use. Comparing a new medication for other types of treatments to placebo or sham treatment by using a randomized clinical trial or RCT design is the most common and rigorous method for establishing efficacy and safety. And placebo use is very popular in mental health research involving new drugs for different types of mental health conditions. The other type of scientific design that's being used in mental health studies and other clinical studies is the so called non inferiority design, in which a new indication is compared only to an active established treatment but it generally requires much larger sample size and are not as definitive for safety and tolerability as similar placebo controlled studies. Usually, the comparator drug is the standard of care, but in new drugs, there is preference for the use of placebo in trying to prove safety and efficacy. What is placebo? It is anything that seems to be a real medical treatment but isn't. It does not contain an active substance meant to affect health. It is something that is given to satisfy a person who has not been given the thing that they really want. It is something tending to soothe your condition. It is used in clinical trials to test the effectiveness of treatment and is most often used in drug studies. Placebo is supposed to bring about a placebo effect. And what is placebo effect? It is the positive effect on a person's health experience after taking a placebo. It focuses on relationship between the mind and the body. It is triggered by a person's belief in the benefit from the treatment and their expectation of feeling better rather than the effect of the placebo. The stronger the feeling, the more likely it is that a person will experience positive effects. It involves a complex neurological reaction that includes increases in feel good neurotransmitters like endorphins and dopamine to greater activity in certain brain regions linked to moods, emotional reactions, and self awareness. This is the usual design in clinical trial involving the use of placebo. They study a population and tries to find out the effect of a drug, and usually there are two arms. One is the new treatment or a new drug, and the other one is a placebo or current treatment. They make use of a randomized clinical trial, which is blinded. Oftentimes, there's a double blind design, and based on these two groups, they measure the common outcomes in terms of clinical outcome, the biomarkers, and the side effects. So that with the use of placebo or a comparator drug, they are able to see the safety and efficacy of a new drug intended to treat a specific disease. The use of placebo in clinical trials is quite very popular, particularly in mental health research. And the purpose of the placebo group is to account for the placebo effect, effects from treatment that do not depend on the treatment itself. So it's a psychological effect of treatment. The regulatory requirements is for the use of double-blind randomized clinical trial comparing the efficacy of new drugs, which is assigned to the intervention arm, compared with placebo or another drug, which is the control group. Comparing something, which is the active treatment, with nothing, which is the placebo, versus comparing efficacy of the new drug with standard of care would constitute the common research design in clinical trials. Placebos are often used in clinical trials as an inactive control so that researchers can better evaluate the true overall effect of the experimental drug treatment under study. If there is such a thing as placebo, there is also what is referred to as nocebo effect. What is nocebo effect? It is a harmless thing that causes harm because you believe it is harmful. So, this is common in some types of diseases that they associate with the work of the devil, and therefore they think that the nocebo effect is the one that causes harm. Treatment can have a placebo or nocebo effect. If you trust a doctor, then he has a positive effect on you, and that could bring about a good placebo effect in terms of your optimism, his empathy, and even neuroticism. As different from the nocebo effect, if you do not trust your doctor, then you are pessimistic about the treatment that is being given to you. It could even result in anxiety and catastrophizing. The power of suggestion is very important. So that, for example, if you're doing research about suicidal thoughts and you start asking the participant if he had thoughts about suicide, he may not have these thoughts, but because he hears about questions asking him if he ever thought of committing suicide, then suddenly he may start to entertain the idea. So, there have been studies measuring placebo effect in psychiatry, and certain factors are predictors of placebo response. It is about the type of personality that you have. It appears to be moderated by patient expectations of how their symptoms might change after treatment. It is also affected by brain networks. The placebo response has multiple neural mechanisms, and they seem to have the same pathway as the respective drug that they are being compared against, mimicking the drug action in a similar but less effective manner. It may also be associated with genes, but the present database of researchers on placebo is currently too small to reliably identify genetic mediators of the placebo response in people categorized as having a mental illness. Definitely, there are patient centered factors. The placebo effect could not be concluded related to age, sex, or ethnicity if it affects the placebo response in psychiatric trials. But it has been seen that the less severe the symptoms of a person's mental illness are, the more likely they are to experience a placebo response to an inactive treatment, as shown in studies in schizophrenia, psychosis, binge eating disorder, and depression. High placebo response was also associated with a short history of illness, although this might also represent the effect of a lower symptom severity. Placebo in mental health research has been studied. For example, in antidepressant and antipsychotic trials, the placebo response would range from 13 to 50% for major depressive disorder, with an average of 31%. For schizophrenia, the mean score is 25%, with a range of 0 to 41%. Hence, placebo response varies widely among studies. Over the past 3 decades, antidepressant placebo differences have declined markedly, with similar findings reported from trials of antipsychotics for patients with schizophrenia. This tells us that there is little difference between the new drug and the placebo arm. What is the ethical guidance about placebo use? Very important ethical consideration is the presence of clinical equipoise, and it refers to a genuine uncertainty on the part of the expert medical community about the comparative therapeutic merits of each arm of a clinical trial. A placebo is therefore acceptable only when there is no established evidence based treatment for a condition according to the relevant professional community. For example, during COVID, there is no effective treatment yet, and therefore the use of placebo in clinical trial is justified. However, when established treatment exists, an experimental treatment should be compared to the established treatment or the standard of care in order to minimize harm to research participants. These ideas are based on the Declaration of Helsinki, the latest version of which is 2013, which states that the benefits, risk, burdens, and effectiveness of a new intervention must be tested against those of the best proven intervention. The use of a less effective intervention is allowed in exceptional situations when no proven intervention exists. The example is COVID, which is a new disease. For compelling and scientifically sound methodological reasons, like it's being used in mental health disorders, the use of placebo or no intervention is necessary to determine the efficacy or safety of an intervention in clinical trials. As a precondition, the patient should not be subject to additional risk of serious or irreversible harm as a result of not receiving the best proven intervention. So, this thinking is repeated by the Canadian Psychiatric Association, which believes that a new therapy should generally be tested against established effective therapy. What is the role of the Research Ethics Committee then? Each proposed clinical trial and population must be evaluated individually by research ethics committees to minimize risk to participants, irrespective of whether a placebo is used. The use of placebo is not acceptable when there is grave risk of clinical deterioration in severely affected individuals. Some clinical examples include acute suicidality, severe acute psychosis, anorexia nervosa with physical deterioration, and severe psychotic mania. What are the benefits of placebo? It is not simply an inert substance. The patient assigned to placebo also benefits from non-specific therapeutic effects, including education, regular visit, psychosocial interaction with the study staff. Placebo response is high in psychiatric and other chronic conditions where symptoms may fluctuate and outcomes are based on patient interview or self report. High rates of placebo response are commonly found among patients with mental disorder. There are many social behavioral researches that are done in mental health, and this could also involve ethical issues. And therefore, it is quite important that the ethical considerations are properly assessed depending on the project details, the type of participants, the risk to participants, confidentiality and handling of data, information and consent form, and conflict of interest. What are the project details? Suppose the study is about suicidal ideation among alcoholics. Then you ask, is it a sensitive topic? Are the researchers qualified to do a research about a mental health topic? Will the research intervention cause possible harm? These are questions asked by the Research Ethics Committee. So it's very important that there's ethics training of the research team with focus on vulnerability, and a member of the research team should be familiar with the rights of persons with mental health issues. We also need to address the conflict of interest of the investigator. This can be financial, this can be professional, this can be related to members of the family doing the study, this is related to time, and this is related to power relationship. The first thing to consider is the vulnerability of the participants. These are persons who are absolutely or relatively incapable of protecting their interests due to insufficient power, intelligence, resources, strength, or other needed attributes to protect their own interests through informed consent. And many types of mental health issues are associated with vulnerability. Vulnerability in mental health research is also about the hierarchical relationship between the researcher and the patient or participant, and there is a potential for exploitation of the patient. There may be a dependency relationship, and therefore this could bring about informed consent issues, giving wrong information, impression that you are being treated when actually you are being made a subject in an experimentation. It's important to address vulnerability, respect the autonomy of the participants. Informed consent needs to be taken from a legal guardian who has the best interest on the rights of the patient if the patient cannot consent for himself or herself. And here it is important to respect advance directives, which are advice coming from the participant themselves on how they want to be treated. Risk benefits would also have to be considered in terms of risk, which may be physical, psychological, social, economic, and political, and the benefits in terms of what they will derive from the clinical trial or study in terms of remuneration, free medicine, access to healthcare and psychosocial support, access to information, increase in knowledge, and improvement of health practices. Privacy and confidentiality are important, and measures should be taken to anonymize names and personal information by using codes in questionnaire, keeping identifiable information under lock and key, getting consent for sharing pictures and sensitive information, password protection, and limiting access to the database. At the same time, there has to be appropriate consent forms, the participant information sheet and informed consent form for sensitive information should be uh, fitted to Two, the type of sensitive information. There may be need for assent for children, the cognitively and emotionally challenged individuals, which may require a legally acceptable representative. But in very simple cases of surveys, waiver of consent may even be granted or waiver of signature in order to protect the confidentiality of information and the names of the persons are anonymized. Oral consent may also be used, and for future use of specimen, broad consent may be given. So all of these things are very important in order to ensure that researches in mental health are being ethically done. So thank you for your attention, and we hope that you are able to learn certain things from my presentation.
Thank you very much, Dr. Torres, for that educational presentation on ethical considerations and issues surrounding mental health research, and also to place great value on ethics training among researchers. And finally, we have Dr. Eric George Cruz, Clinical Associate Professor from the Department of Psychiatry and Behavioral Medicine of UPPGH College of Medicine, Manila. He is also the Corporate Secretary of Mind Institute.ph and the Consultant Psychiatrist of several mental health hospitals. Dr. Cruz will be presenting technology-based mental health research, issues, and challenges.
Good morning. Thank you for joining us in the third of a series of webinars for the first Philippine Mental Health Research Summit. I am Dr. Eric George Cruz from the UP PGH Department of Psychiatry. I will be presenting to you the topic of technology based mental health researches, issues, and challenges. This is my disclosure statement. For today's lecture, this is our agenda. First, I will be talking about a research done in 2018 in the United Kingdom in which the results of the study shortlisted the top 10 research priorities or questions wherein technology may be used for mental health related researches or services. Second, I shall discuss a 2019 National Institute of Mental Health's article on the pros and cons of using technology in mental health researches and services. Third, I will try to relate how the pandemic forced mental health services to adapt or embrace technology rapidly. Lastly, I shall show a few slides on examples of how technology is currently used in mental health researches and services. Shall we begin? In a 2018 study conducted by Chris Hollis and his colleagues in collaboration with the James Lind Alliance Priority Setting Partnership for Digital Technology in Mental Health Care, after removal of out of scope questions and a comprehensive search of existing evidence, they were able to list the top 10 research priorities or questions identified by consensus at the stakeholders workshop and by inductive thematic analysis of the two surveys done from 2017 and 2018. I shall present in the following slides the top 10 research questions for digital technology in mental health care. But first, we shall define what we mean by digital technologies. The Hollis study defined digital technologies as referring to all interventions, tools, and services using information communications technology with the intention of benefiting or improving people's mental health, whether used in conjunction with or independently of mental health services. Such services include but not limited to remote therapy, diagnostics, treatment support, monitoring and self management, and potentially transformative approaches such as virtual reality, avatars, and robots. Information communications technology includes the internet, personal computers, laptops, tablets, social media, mobile phone applications, and wearable devices. Hollis excluded technologies that people with mental health problems cannot access directly or interact with themselves, such as electronic health records and other healthcare administrative systems. Okay, next we discuss the top 10 listings. First, on the top of the top 10 list, what are the benefits and risks of delivering mental health care through technology instead of face to face? And what impact does the removal of face to face human interaction have? The COVID 19 pandemic forced most mental health care delivery to go online. The lockdowns of cities worldwide and, of course, in our own country make it necessary to hold clinics online for most of us in the mental health industry. Online consultations made it convenient for patients and for doctors themselves to hold clinics. They do not have to go through Manila's congested streets just to see us. And how about risks associated with online consultations? Patients may fraudulently misrepresent someone else, especially for voice only related services. Would removing real face to face human interactions even matter in delivering mental health care? Researchers on this topic would be needed to further improve an existing system or to maintain such systems beyond the pandemic era. So let us move to the next item on the list. How do certain mental health conditions affect how people engage with technology? We know that persons suffering from a mental health illness like depression may choose to be seen online than face to face, likely due to their preference for isolation. Would online consultation make it riskier for persons suffering from depression because we inadvertently reward their self-isolation? Or on the other hand, would online consultations for depressed individuals be be of an advantage because it makes it easier for them to contact a mental health provider? I had a new patient recently that prefers a face to face consultation because he is suffering from paranoid schizophrenia. Consultations online for that individual would not be beneficial because he feels we are being monitored by the NBI online. Thus, a particular type of mental health condition may or may not be suited for digital mental health. More specific studies or researches for a specific mental health condition utilizing technology are needed. Next on the list, how can treatment outcomes be maximized by combining existing treatment options with digital mental health interventions? Traditional face to face consultations or therapies are generally combined with psychopharmacological interventions. We are all used to that paradigm pre pandemically. However, there are numerous mental health related applications on Android, Play Store, and Apple Store that claims to be useful or helpful in improving mental health conditions. I guess the question here is how to prove that those applications are effective and how can we incorporate such applications or other digital mental health tools to our daily clinics. Fourth on the list, at what point in the care pathway are digital interventions most safe and effective? Are digital interventions best started prior, during, or after? Studies on the application of digital mental health interventions on crisis intervention, prevention, engagement, treatment, maintenance, and recovery are needed. Can digital mental health differentiate urgent from emergency conditions? These are just a few of the issues and challenges that I can think of so far. But wait, there are still more. So we go to the next slide. How should apps for mental health be evaluated and endorsed? Should professional mental health societies like the Philippine Psychiatric Association, the Philippine Neurological Association, or the Psychological Association of the Philippines be tasked to evaluate and or endorse such technologies? Or should patients' organizations be given such tasks? How can we make sure that endorsed digital products are free from conflicts of interest by the body that endorsed such products? Should government be tasked to evaluate, or do we let civil society or the private sector to handle it? Studies may be needed to answer such politically and economically complex decisions so that we can have an objective and unbiased endorsement. Moving on to the next item, what impacts will the adoption of digital technology in mental health services have on capacity, access to services, waiting times, and preferred appointment times? Due to the COVID-19 pandemic, in my opinion, it made it relatively easy for my patients to receive mental health services. Patients can easily ask for a medical certificate or have a refill of their prescriptions. Pre-pandemically, patients had to wait for their next visit to receive such services. This is just one of the examples that technology made the delivery of mental health service more efficient. Studies on the use of digital technology in improving service delivery are needed to promote such innovations to mental health services. Next slide. Are therapies delivered via digital technology as effective as those delivered face to face? Past studies have proven that online psychiatry consultations are comparable to face face consultations. However, how about delivering psychotherapies, for example, like cognitive behavioral therapy? Would a hybrid digital face to face psychotherapy be as effective as our usual face to face psychotherapy alone? Numerous CBT-based applications are available online. Most are free, and others you have to pay for further use. Researches on specific psychotherapy that are enhanced digitally or purely digitally delivered are needed to allow more patients to receive such services. Progressively, studies on their effectiveness should follow. Next slide. Can the common elements of therapy, like empathy, gestures, nonverbal cues that come from person to person interaction, be maintained with digital technology interventions? So basically, can a robot replace our usual human therapist? I wish I could live forever because I would like to live and see it for myself. However, would that spell the demise or obsolescence of your friendly neighborhood psychiatrist? Algorithms for intelligence have been around for decades. The moment you Google a search item, an intelligent algorithm is triggered so that your next search term are related to the topic you've been browsing. AI technology have not yet been able to develop an algorithm that instinctively recognizes social cognition. Social cognition is a very complex mental task that is difficult to convert into ones and zeros or binary languages. Numerous applications that are AI enhanced would just follow a logical statistical probability depending on the last input or a combination of the answers you made previously. Researches on the practical and applied use of AI in the delivery of mental health services is a wonderful area of study in the future. Next slide. Do digital health intervention increase reach and access to groups and people less well served by traditional mental health services? Like, for example, Asians, Blacks, ethnic minorities, men with depression, people in rural areas, etc. This is a worldwide question that strives to make mental health care accessible to all people on Earth. One advantage that digital mental health technology brings is that it won't care what color your skin is, it won't care how old you are, it won't care what other medical conditions you have. However, an opposite effect may also happen. Technology can be programmed to just limit access to a select few. The COVID-19 pandemic made me realize that digital mental health technology is here to stay. For example, a patient of mine from Iloilo that I see in my clinic once or twice a year can now book an appointment whenever convenient for her. This is just one example how digital mental health can provide access for rural areas. A lot more can be done. Researchers on feasibility and access to digital mental health may allow governments to appropriate funds for such services. Last on the top 10 list, how can social media be used more effectively to bring more people with mental health problems together and help them connect rather than isolate them in their homes? As I have discussed previously, studies on the appropriate use of digital mental health to specific mental health conditions must be performed. In my opinion, social media is both good and bad. Good because it is a platform that people can connect with one another to share thoughts and collectively allow debates to happen. On the evil side, social media also allowed fringe beliefs and false information to propagate easily. Anecdotally, I notice in my clinic that a good number of my patients are affected by issues that are related that they read in social media. Social media triggered my patient's anxiety and her negative view of the world. On another note, patients from our hospital uses social media to form support groups for themselves and their families. A lot more studies are needed to determine at-risk populations wherein we can suggest the benefit or risk that social media poses for them. In the next few slides, I summarize an article published by the National Institute of Mental Health in 2019. I will briefly discuss the pros and cons of digital mental health technologies. Shall we begin? Digital mental health technologies offer convenience. Treatment can take place anytime and anywhere. Example, at home, in the middle of the night, or on the bus on the way to work, and may be ideal for those who have trouble with in-person appointments. Anonymity. Patients can seek treatment options without involving other people. A college student patient of mine recently booked an appointment for an online consultation with me. During my assessment, apparently the patient did not want her parents to know she failed a subject in school. Online consultation made uh, a mental health assessment for anxiety stress-free for that patient. An introduction to care. Technology may be a good first step for those who have avoided mental health care in the past. Thus, mental health technology serves as a paved pathway for continuity of care. Lower cost. Some mental health apps are actually free of charge or cost less than traditional care. However, be aware not to mindlessly click yes unless you want to get your credit cards charged inappropriately. Service to more people. Technology can help mental health providers offer treatment to people in remote areas or to many people in times of sudden need. Example would be natural disasters or terror attacks. In 2005, or I guess in 2006, Dr. Lourdes Ignacio spearheaded the development of a telepsychiatry service in Infanta, Quezon following a disastrous landslide in that province. Unfortunately, 3G cell phone technology at the time was in its infancy, making it difficult to have a real-time synchronous assessment. Interest. Digital mental health promotes interests. Some digital mental health technologies might be more appealing than traditional treatment methods, which may encourage patients to continue or finish therapy. I noticed that in my patients younger than 25 years of age, they preferred online consultations and had consistently not missed an appointment compared to pre-pandemic face-to-face appointments. 24-hour service. Technology can provide round-the-clock monitoring or intervention support. Locally, one of the possible hindrances would be sustainability of the service. We found out that it was relatively expensive to and maintain a 24-hour service without institutional or or NGO or government assistance. Consistency. Digital mental health technology can offer the same treatment program to all users. For example, a CBT based mental health application can be consistently administered repeatedly for every patient who engages in such services. Support and monitoring. Digital mental health technology can complement traditional therapy by extending an in person session, reinforcing new skills, and providing support and monitoring. A simple application that reminds a patient to take their medication is a good example of this. Objective data collection. Digital mental health technology can quantitatively collect information such as location, movement, phone use, and other information. As long as apps conform to the Data Privacy Act for local applications, such technologies can prevent COVID infections to spread. Example would be the Red Cross 143 app and the Stay Safe PH application that we use today for contact tracing. Although for mental health purposes, applications that collect such information may need further legislation or regulation to protect vulnerable individuals. For, s- for some of the known disadvantages of digital mental health technologies, the NIMH article mentioned the following. Effectiveness. The biggest concern with technological interventions is obtaining scientific evidence that they work and that they work as well as traditional methods. Both are apples, but which one would be preferred? The tastes are different, but the difference is not necessarily bad. For whom and for what? Another concern is understanding if apps work for all people and for all mental health conditions. As I have mentioned earlier, the technology may not fit all patients' condition. So as a mental health provider, we need to know our patient and plan well their suitability. We need to hit the same target every single time. Privacy. Apps deal with very sensitive personal information, so app makers need to be able to guarantee privacy for app users. Compliance to data privacy regulation by developers must be monitored, but by whom? Guidance. There are no industry-wide standards to help consumers know if an application or other mobile technology is proven effective. Towards the end of my lecture, I will discuss a link to a website that may be helpful in guiding your decision about which apps to use and download. The website is not endorsed by any professional society, but at least the website provides details how they rated the application. Regulation. The question of who will or should regulate mental health technology and the data it generates needs to be answered. I guess in our country, after signing of the Mental Health Act of 2016 into law, the Philippine Council for Mental Health, or PCMH, the policy making body created by the mental health law, may be tasked to regulate, or the PCMH can establish a committee to regulate technologies for mental health. Overselling. There is some concern that if an application or program promises more than it delivers, consumers may turn away from other more effective therapies. Since most mental health applications are not regulated and have not passed through the rigors of trials for effectivity, mental health providers must still guide our patients for now which one they should be using. Okay, down to our last 5 to 7 slides. How relevant was digital mental health during the COVID-19 pandemic? Next slide. In mid 2020, there was a frantic effort to establish internet connections, protocols, set up online consultation sites, learn how to send prescriptions digitally, and for others, do psychotherapy online. Recently, an article claimed that the Philippines ranked highly worldwide in downloading mental health related applications. I hope we do gather data now to facilitate further researches in the future. A few examples of digital mental health technologies before we end the lecture. Shown is an example of a website called One Mind Cyber Guide that lists and evaluate mental health related applications that we can download and install into our devices or gadgets. The One Mind Cyber Guide website evaluate each application as to their credibility, user experience, transparency, and offer professional reviews of the applications they listed. It may offer some guidance as to which application may be appropriate to your individual situation or your need. Okay, my last slide. I just listed other modalities or technologies that can be utilized in conducting and evaluating and analyzing mental health related issues. To explain all of them requires another 45-minute lecture as well. That we don't have that time. So with that, thank you for the privilege of your time. Stay safe, get vaccinated, and thank you again.
Thank you very much, Dr. Cruz, for that very informative presentation. This is very timely as we are becoming more reliant on technology, especially in the context of the pandemic. Technology has indeed opened a new frontier in mental health support and data collection. Now we move on to the much awaited portion of this activity, the open forum or the Q&A portion. This session will be moderated to us by Dr. Carissa Joaquino Malicaso, the chair of Webinar Series 3, Leadership and Governance, and will be joined by Dr. Carl Abelardo Antonio. Dr. Antonio is an associate professor and university scientist at the Department of Health Policy and Administration from the UP College of Public Health, Manila. Dr. Malicaso and Dr. Antonio, you now have full control of the session.
Magandang umaga sa inyong lahat. Good morning sa iyo, Dr. Carl. So we have come to the much awaited portion of the series 3. But before we do that, I would like to acknowledge the members of our panel this morning. So of course, we have our speakers, Dr. Jasmine Vergara, Dr. Cristina Torres, and Dr. Eric Cruz. Mayor Treñas is not around because the staff and himself, they are all busy with the vaccination program in Iloilo City. But together with us also is Dr. Leonor Cabral Lim. She is the chair of the Technical Committee on Research of the Philippine Council for Mental Health. In attendance, although not directly in the panel, is Dr. Ignacio, who is the chair of the Technical Committee on Capacity Building. We also have Ma'am Lucita Lazo, president of the World Association of Psychosocial Rehabilitation and member of the Technical Committee on Research. Ms. Presi Cuevas, who is the program head of the National Mental Health Program of the DOH and member also of the Technical Committee on Research of the PCMH. We also have Dr. Agnes Casino from the National Center for Mental Health and other members of the Technical Committee for Research of the Philippine Council for Mental Health who are present as participants are Dr. Dina Nadera, Dr. Violeta Bautista, and Dr. Ems Sevilleja. Okay, Carl, maybe you want to start?
Thank you, Dr. Giacchino, and good morning to everyone. It's a great pleasure to join you in this discussion. So maybe I'll start with first question for Dr. Vergara, and there are some clarifications regarding the approach done in the costing for the economic cost for mental health in the Philippines. One of the question is how was this done, and there's a follow-up question that just came in whether in the indirect costs the transportation, food, caregiver cost, and time lost during travel were factored in the analysis of the cost that you presented earlier.
Thank you for that, Dr. Carl. As mentioned, we have used the One Health tool to divide to estimate the direct and indirect costs. So just to briefly go over what were estimated, at least estimation of the total government expenditure on mental health, as we have seen the direct cost expenditure, PhilHealth packages that were subsidized. The estimation of the indirect economic burden, this was calculated from the full-time worker in the Philippines from divided by the total employed labor force. So they have to gather those elements, the mental health conditions and the worker productivity, some elements of the workers with the mental health conditions. Kasi dinidoct, let's say, of the total labor workforce from more than 15 years. How many people with mental health conditions that are employed or with reduced employment? So those were calculated. I'm not sure if we have captured the transportation elements there, but we know that with absenteeism, the employee was not able to go to the work because of the mental health conditions. And then the presenteeism was in definition, even if the employee is present at work, the employee has reduced capacity to perform tasks and all. That was also considered. So it can be in the form of he has or she has a mental health condition, anxiety, depression that have produced that. So those are elements, but I won't be able to go in detail. But as mentioned, I shared the guidance note where they can find the concrete elements of how it was conducted. And as mentioned, we'll provide more specific explanation on the full report. Thank you.
Thank you. And the full report, if I saw in your reply in the chat box, will come out in October.
Yes.
Thank
yes,
you.
Dr. Carl. That will be with Mompresi, of course, with the Department of Health, and the multi-sectoral people that were also that has also took part in the mission last year, early last year before the pandemic, together with the UNDP, UN Interagency Task Force on NCD, with WHO and other key stakeholders. Look out for that.
Thank you, Dr. Vergara. Over to you, Dr.
Our next question is for Dr. Cristina Torres. And the question is, are literature reviews also subject to ethical clearance, po?
If you are only doing literature review, it has to be stated in the methodology, but you still have to apply for ethical clearance and you can merit an exemption. Exemption is only granted by the ethics committee. So when you submit the protocol, you say you're applying for exemption because this is only literature review, and the ethics committee has to consider that and grant you a certificate of exemption.
Thank you, Dr. Torres. Carl?
Just to follow up with Dr. Torres, there was a lot of excitement generated by the presentation by Dr. Cruz earlier about the use of technology and the potential for further research in this field. And I was seeing some comments in the chat box about some students interested in this kind of research, maybe in the engineering field or ICT field. But I also noted that you mentioned in your presentation that one consideration for in the assessment of the ethical soundness of the research is the competence of the researcher. So can you maybe provide us some guidance on this if students would want to engage in research looking at how to integrate mental health, digital health, or digital technologies to mental health services?
So it's a question for me?
For Dr. Torres first and then for Dr. Cruz, please. Thank
Okay.
you.
The use of technology in research is subject to ethics review. And the reason behind this is the type of vulnerability. I have focused on vulnerability. And the function of the ethics committee is to make sure that mental health patients or mental health participants are protected in a research about technology as well. So it depends on what kind of participants you are involving in your research. It depends whether it is anonymized or they are identified. So these are the issues. It depends what kind of technology is being used, what is the design, and therefore research in technology should also pass through an ethics committee to be able to identify what are the ethical issues. And most of these are related to privacy and confidentiality. As we all know, there is a Data Privacy Act, and mental health participants have a right to privacy. And therefore, we check whether the confidentiality of information is being protected by the researcher. Thank you.
Thank you, Dr. Torres. Dr. Cruz, please, a comment on this issue on the ethics of conducting research using digital
Yes, a
technology.
question. Okay, wait. Is my microphone on? Yeah, can you hear me, right?
Yes,
so I
sir.
guess the question is competency in conducting research, correct? So
yes,
yeah, I guess ever since, probably because I have the luxury of actually being involved in numerous clinical trials here in the Philippines. In terms of competency in the past, siguro 20 years ago, and I was still a resident can actually join a clinical research trial. But nowadays, for the past 10 years, the US FDA actually required they required actually a competent individual, which actually, let's say, as a psychiatrist, you have to be recognized in your field. As a psychiatrist, you have to possess for us the diplomate degree. So I guess in terms of competency, it's often required in all researchers nowadays because you have to submit your CV once you actually make or apply for any researches. And we do get trained even earlier on to, I think Dr. Trina touched on it in ethics of placebo control. Even for us, we do get trained to avoid inducing placebo effects. So yeah, competency is actually a requirement for all researchers.
Thank you, sir. Over to you, Dr.
Carl, there is actually a follow-up question for Dr. Vergara. The question is from Dr. Ignacio, and she's asking whether mental health investment in WHO in the Philippines will have room for research in addressing the broader conceptual framework in mental health now adopted by the Philippine Council for Mental Health, which is beyond the clinical and is more biomedical in perspective.
Thank you, Dr. Teresa, and thank you, Dr. Ignacio. With the current tool that we have for the investment case, even at the global rather, it is it focuses on the treatment packages as mentioned in the clinical context as defined with Dr. Ignacio, that has been some evidence base. It has some limitations, unfortunately, and it has yet to actually, while the evidence is still coming, so it has yet to cover those elements of beyond the clinical perspective. However, in the mission, even in the exercise, and as mentioned, the institutional context analysis is also considered for the Philippines, having to cover also other elements beyond just the psychosocial aspect. But with the computations, this has not yet been factored in. Thank you.
Thank you, Dr. Jazz. Carl, can we ask Dr. Cruz? There were some questions here for Dr. Cruz. Eric, the comment is, comment and question, I think. It's mental health technology can indeed reach the rural areas. However, we also have to think about the internet strength capability in rural areas. Also, Eric, do you know the percent of people in the rural areas who have mental health issues? Is that something that we have?
There's actually two questions. There's actually two questions.
Okay.
Right? In addressing internet connection in rural areas, I guess I'm not competent enough actually to answer that. That's actually a private sector initiative or even a government initiative. Countries like Singapore, which funded their infrastructure because the government funds the pipeline or the backbone for the internet. In the Philippines, I know it's a private sector initiative, so we depend on them. So yeah, a good internet service provider would be that, because you need a good synchronous activity to actually enable to see your patients, to interact with them, and actually look at the face or the nonverbal cues when you do an online consultation. Kaya nga, way back in 2006 or 2007, I can't remember, Dr. Ignacio started in telepsychiatry, because telepsychiatry is already known to be a good service that we can actually have online. The problem is during that period, 3G technology was in its infancy, mabagal pa siya. Hindi pa siya as robust as what we have right now. So internet connection should be provided to all. If that's something that I don't have answer, parang wala akong, I'm not in a policy position actually to do that, but I guess it's a government initiative if you really want it to percolate down to the rural areas. Okay, the second question, if I know any percentage, I think we have in our departments at PJ, Dr. De Guzman is actually spearheading this study on the Philippine National Survey for Mental Health and Well-Being. I think I can't remember the specifics, but I guess it's a survey, so it may produce the data that we need. I guess it's an epidemiological study. Yeah. So,
but
I don't have it
Eric,
yet.
The results are not yet out. Okay.
Still ongoing.
Yes. Carl?
Yes, ma'am. I think I'd like to give a follow-up to the point on the use of technology still, while we have Dr. Cruz, and then maybe link it to the presentation earlier by Dr. Vergara on the cost. And how much, is there a difference in terms of the cost for the services provided face-to-face compared to digital technology? And are there initiatives maybe at these kinds of digital-based services? Maybe Dr. Cruz first.
I guess the question would be, is it the same? Do you pay for the same, sir? You pay the same or the same way than we have been doing it for the pre-pandemically? Depends on the clinician. I guess anecdotally, I can only mention my practice. In my practice, I charge the same. So what I give during pre-pandemic, how I interact with them, the amount of time that I get involved in assessing my patient would still be the same. So in terms, I guess there's no mandated digital cost for consultations, but the cost would be still the same, at least anecdotally. And I guess most of my friends that I know would have the same costing. Depends on the area. Some people, some of my colleagues who practice near PGH, which is the catchment area, kasi syempre, iba yung catchment area, they charge what they charge prior to the pandemic. Would there be added services in terms of digital mental health? Yeah, I guess, sabi ko earlier on, it's easier for patients to connect with us now. Unlike before, I had this patient from Iloilo, which I included in my slide. I only see her twice a year pre-pandemic, because of course, the cost of going to Manila and seeing her face to face. But now it's easier for her to book an appointment, see her when it's convenient for her, and if she needs me. So she just contact my secretary and we hook up for an appointment at a specific date and time. I answer the question?
Yes, sir. Thank you. How about the insurance coverage? Would you be aware before I pass the mic to Dr. Vergara?
I may not be aware, but I guess some private institutions would carry that because most psychiatrists are not under any insurance policy. They're not within the insurance system because insurance companies relatively charge low for our services. I guess most of us, there are only a few. I think you can count them with your fingers among the 600 psychiatrists in the Philippines. There are only few who actually voted or actually involved in an insurance company. So I may not know.
Okay, thank you. Maybe from the perspective of Dr. Vergara, and I think there's also a question in the Q&A box about PhilHealth coverage, maybe for mental health conditions in general, and for e-health and telepsychiatry services in particular.
Thank you, Dr. Carl. At least in the context of the investment case in 2019, that's the crucial gap. There's a lack of insurance coverage for outpatient services. So I believe I think Ma'am Presi would be able to focus and respond on this further, that most of the coverage for mental health conditions are mostly inpatient. So that's another thing, that if we want to invest in putting money, let's say, on specific coverage, some results of the investment case can help shape that, how to allocate those resources. And if you have, let's say, this budget allocated to mental health, which are the top conditions that I could cover, to have a more impactful increase in coverage. So I believe that is something that's being further shaped. I would probably pass that on to Ma'am Presi of Department of Health. Thank you.
Thank you. Over to you, Dr. Dupino.
Yes, Carl. There is a question for Dr. Torres in the list, and the question is that there is now a new framework on mental health adopted by the Philippine Council for Mental Health, and have members of the ethics committees been oriented and briefed about this new framework, Ma'am?
I think there is need for communication between the Mental Health Council and the Ethics Committee. We cannot just assume that we know what are these guidelines, but I suppose it is not about research. And we also feel that we have to be consulted when it comes to mental health research. So I think the discussion should be initiated in a forum like this, so that there is a meeting of minds, and when we review protocols, we make sure that the guidance are properly considered and how to interpret the guidelines in research.
Thank you, Dr. Torres. There's another question, and I'm not sure, ma'am, if this is for you. I will read it, and maybe you and Dr. Cruz can answer. Aside from safety, privacy, and confidentiality of the participants, part of ethics considerations is also the safety of the research proponents, particularly if they will be exposed to participants with mental health concerns. How will researchers handle the sensitive data they collected such that they will not be affected by the stories they hear or when they work with at-risk participants?
If I may answer that first, one of the things that we evaluate in an ethics committee is the qualification of the researcher. And I think this has been mentioned by Dr. Cruz, that if you are a psychiatrist or you are a psychologist, you know about this, you know what topic you are getting into, what are the risks when you do research on this topic. And as a professional, you are supposed to know how to handle this. No? And therefore, for example, in ethics committees, the researchers of undergraduate students that will deal with vulnerable participants, most ethics committees would require the inclusion of the advisor because the undergraduate students may not have the necessary skills to be able to handle problems that they may face related to their own safety. So we assume that when a researcher submits a protocol, that the researcher understands all these things, no? What is he getting into? What are the risks of doing this research? But at the same time, we in the ethics committee also evaluate your experience and your training. Do you have the capacity and the competence to be able to handle such researches? No? So it is an assumption, no? And therefore I was only talking about privacy and confidentiality because the basic requirement is for a qualified researcher to be able to do a risky or a low risk research. So that's a very important consideration in an ethics committee.
Thank you, Dr. Torres. Dr. Cruz, would you have some comments?
Yep, thank you, Dr. Torres. Okay. So I guess there are two issues here. You mentioned safety and confidentiality of research participants. All researches that are actually reviewed or that we submit to the ethics review board should be actually read by the ethics review board. The methodology of the research should actually state there if there, for example, if you're handling a vulnerable population, if your subjects are vulnerable to begin with, there must be contingency plans on how to handle. Let's say, for example, you're doing a case study or a survey on patients having depression, and you found out that there are one or two of your research subjects who are currently suffering from, let's say, severe illness at the time that you conducted the research. How would you actually handle that? Because as a researcher, we cannot do anything about that patient, technically. However, it should be in your methodology, actually, that you should refer this patient to a qualified or let's say in your institution that safeguards that patient. Once you identify this vulnerable patient is actively in a depressive state that may be quite severe enough that they need consultation, yeah, a patient should be referred. The next one would be confidentiality. All researchers must handle research data appropriately. That's why during the encoding of private data, I think it's called, in the United States way back. I think it was president. I think the Clinton era who propagated or signed yung HIPAA compliance. Basically, HIPAA compliance makes sure that all healthcare information that is actually handled by your insurers and they should be handled appropriately so that you protect the confidentiality and validity and privacy of those personal data. And those personal data, if we use it in research, we don't submit personal data to the, let's say, to the analysts. However, we do have a repository of their encoded, let's say, their names are converted to a number. So we know eventually if something happens, we can actually identify that patient. But the researchers or people involved with that research or even the ethics committee or everyone else within that system would not even know who the participants are because it should be in their methodology that these patients are kalimutan ko yung research term for it, but they should be, I think it's anonymized. You should anonymize your research subjects. And that is already a requirement. Yes, 20, 30 decades. It's 20, 40 decades ago pa. I guess.
If I may add, no.
Yes, Doctor.
It's very difficult for us to give generalizable statements, no? And may I say
that each protocol is evaluated individually. So we look into the details of the protocol. I cannot tell you now that, oh, this type of research you cannot do, or students cannot do, and things like that. An ethics committee has to apply the guidelines specific to a protocol. And therefore, that's the reason why you are required to submit your proposal, because the risk in one proposal is going to be different from the risk of another proposal. So we look into that, we go into the details. What are the risks in terms of privacy and confidentiality, in terms of medicines being given, in terms of risk to the community. So all these things have to be evaluated, and therefore that is the purpose. That is the reason why you have to submit your individual protocols to an ethics committee, because the decision is specific to a protocol and to a researcher.
Okay, thank you, Carl.
Yes, I think we have a couple more questions before we entertain, because I see some raised hands in the panelists and the attendees.
Yes.
But this is a question for Dr. Vergara. We noticed that in the list of the conditions that you included in the costing study, drug use disorder is not part of the conditions, but only alcohol use disorder. Maybe you can mention something about this and whether you plan to include drug use disorder in future costing studies.
Thank you, Dr. Carl. As mentioned, these are I would say probably first few focus that are evidence based. So currently, we even also discuss this at the global level, kind of like how are we going to look into the other causes. So most likely, as mentioned, when the evidence comes in, or while the evidence are coming in, rather, further conditions or other elements that were raised also by Dr. Ignacio can be covered. But these were just the focus, the 6 conditions and some population-based intervention for promotion and prevention. So sa ngayon, ito po muna, kasi ito lang po yung may evidence. And as I believe even in this UN interagency task force on NCD, it's the Philippines that's first conducted this mental health investment case in this context. There are other countries who conducted it, but it's the Philippines who first conducted this under this interagency. So while we're going to be evolving, eventually more elements might come in. So we look also forward for that. Thank you.
Thank you, ma'am. Over to you, Dr. Jokino.
Yes. There is a question here. Actually, there are many questions in the chat box, Carl, and some of them I think can be answered by other people. But the questions for our speakers, there is one more here. Are there guidelines in utilizing digital technology as a tool to implement interventions to clients?
I personally, I may not have any knowledge on any published guidelines specifically for the Philippines, but there are established guidelines abroad. Okay, so I guess ever since telemedicine was actually born, way back, 30 years ago, I guess, there are already guidelines on how to approach digital teleconsult or telemedicine. It was, bata ko pa nun, I guess 20 years ago. There are already studies on telemedicine that sinira which subspecialties kasi who would benefit more, would the best for telemedicine system. Studies show that it's dermatology, pathology, radiology, and psychiatry. These are the 4 that would benefit most for, say, purely digital or a hybrid system of digital health. Okay, why? Because I guess compared to other subspecialties of medicine, you can conduct your diagnosis treatment without actually physical contact or face-to-face interaction. to a minimum. Of course, there would be standards of care on how to do it. For example, psychotherapy. I don't know if we define how many hours, how many hours we should, but contextually all over the world, psychotherapy should be done at least because it's some insurance company would pay for it. So I think it was for them, it's 30 minutes to 45 minutes. And if you do psychotherapy and you charge for psychotherapy, then you should engage with your patient 30 to 45 minutes. In the Philippines, I don't know yet. I'm not the best competent person actually to answer that. I guess that's why the Mental Health Act was recently signed into law. The guidelines are being published, and that's why the Philippine Mental Health Council is there to help us draft all those policies. Did that answer your question? Thank you.
Thank you, Eric. Actually, there are some people who are answering or giving comments on the chat box, and it says that the American Psychological Association has actually sponsored a 4-segment webinar with certification on telepsychology, and that I think the same body, APA, actually has guidelines.
Even Harvard at that.
Yeah.
There's a Harvard telemedicine webinar that you can actually, COVID, during the pandemic, they offered it for free.
Yes.
Okay, so.
Eric, would you know, there is a small question here. Would you know if there is anybody that monitors Filipino behavior on social media utilizing technology and data analytics or something like that? Would you know if there is something like that?
I may not, probably, I'm sorry, but I don't know.
I think that's a specific study that has to be taken as part of research.
Oh, nga po, Doktora. Okay, Carl, did you come upon other specific questions?
Yes, ma'am. For Dr. Torres, it's actually a question and a comment. Because one of the participants said that is asking if how to cascade, the idea of research ethics to schools, because many theses are done by student researchers do not follow the guidelines that you mentioned earlier in your presentation.
I think that research ethics has become part of mainstream practice today. And if you are an academic institution that is doing research, then it is important that research ethics is taught in the schools, And I think in UP, we have already developed a system so that all types of researches would undergo some kind of ethics review. And this is the best practice in advanced countries and advanced universities, because particularly in the field of health, your research articles will not be published if you have no evidence of ethics review. So I think the way to cascade this body of knowledge is really for the institution to come up with a policy that will require training in research ethics of researchers, its faculty, and based on that, create a research ethics committee, because the protection of human participants in research is now a very important component of education. So it is to be done through a decision of the policymakers. And I think in the Philippine health research system, you will have CHED as a partner. You would have the University of the Philippines as a partner. You have the Department of Health and the Department of Science and Technology as partners. So it is formally organized. There's a Philippine Health Research Ethics Board that would come up with guidelines. UPNIH is doing training. PREB is doing training. So I think there are now many venues that are available in order to mainstream research ethics. And if I may share, one time I was invited by the Philippine Normal University, and the reason they invited me to speak about research ethics is that they will not get the collaboration with an Australian university if they do not have a research ethics committee in their campus. So that is the current development, and I think we should make use of the opportunities in order to share this kind of knowledge with the academic community. Thank you.
Thank you, Dr. Torres. And just a follow-up to that, there are some participants who commented that, like De La Salle and UERN, they already have ethics committees. But one participant asked, what if they don't have an ethics committee yet? What if they are in the process of forming an ethics committee yet? What are the options available to them?
Of course, to mainstream it, it has to be part of the curriculum. But for your proposals that will need ethics review, the system that is currently adopted in the Philippines is to submit your protocol to an accredited ethics committee. So there is this system of oversight where one institution with an accredited ethics committee by the Philippine Health Research Ethics Board can review protocols for you being done in the hospital or being done in the academic community. So you just have to look at the list of research ethics committees that are accredited by PREB, and you could start this conversation, and if they agree, they can exercise oversight over your institution, meanwhile that you are preparing your research ethics committee.
Thank you, Dr. Torres. Over to you, Dr. Duquina, please.
Okay, Carl. I'm going to ask some questions, not from our speakers, but maybe from the other members of the technical committee for research who are present. There is a question here. It says, aside from internet connection issues, the distribution of mental health professionals such as psychologists and psychiatrists are unequally distributed, mostly in big cities. What are the moves to address this issue? And then there is another question, are there any successful community-based projects related to mental health in the Philippines? Because she's interested in the research topic. So can I hear from Dr. Violeta Bautista or Dr. Dina Nadera, if they are in, I think they have been given access. Ma'am Dina or Ma'am Bolet? If they are not there, Dr. Ignacio or Eric might be able to answer too.
I can answer one. If psychiatrists are concentrated in urban areas,
yes.
One thing I can think about is economics. Like for example, why do we concentrate in Manila? I guess most of the institutions that train psychiatrists are in the urban centers. There are a couple sa Cebu, tama ba ma'am, Dr. Ignacio, sa Davao, Zamboanga. So basically, yeah, they do train, but why in the urban centers? For me, I'll say anecdotal ulit. I don't have any research kasi on it why, but anecdotally because I guess it offers economic advantage for us because it's about standards of living. So I guess it offers that ability for us. Yeah, I don't know. So, but if the government would offer incentives to actually divulge all, send all psychiatrists into the rural areas. I'm not a policy making person. Kasi Dr. Ignacio. Thank you.
May I that?
Yes, Dr. Tar.
With the passage of the mental health law, there has been initiatives to bring mental health wellness into the communities. No? And I see that in the protocols that we review. So it's not only about psychiatrists, it's about social scientists, psychologists, people involved in behavioral sciences, conducting community-based training, doing research in the community. So I think it's about funding these initiatives so that mental health is not only associated with the more advanced urban centers, but the passage of the mental health law has opened a wide field of activity, not only limited to the clinical care, but also related to community support. For example, I have seen rehabilitation programs being initiated by behavioral scientists in the community, and they apply for funding. So this is also a mental health topic. So I think we need to explore the different areas that have been opened up with the passage of the mental health law.
Okay, Dina, can you answer that?
Yeah, thanks. Bale, I think it also has to do with governance, since we're talking about governance in this series. No, the distribution of the psychiatrists is primarily city-centered. First, because they have a lot of opportunities. Many psychiatrists would work part-time clinics and part-time academe, or part-time government, part-time private practice. So they have opportunities to juggle. It's very difficult because if you're full-time psychiatrist in one place, you also need some change of routine, some change of environment, some change of setting for you to be able to work just like any other specialist. And the other thing which has to do with governance is the lack of items for psychiatrists in government hospitals. So government hospitals in other regions, for example, would actually prioritize obstetricians, internists, pediatricians, and surgeons for their hospitals, because these are actually bringing in also some return of investment in terms of the PhilHealth accreditation. So it's difficult for government hospitals to put in items for psychiatrists. Right now, I think in terms of, I'm trying to relate everything to governance because this is the meat of the series. In terms of improving the distribution of professionals, mental health professionals in the different countries, first there has to be opportunities, there has to be job items. For example, even the guidance counselors napakababa ng kanilang salary grade. And not all universities would actually follow the Republic Act that actually governs the practice of guidance counselors. Next, psychologists. There are no items for clinical psychologists in even community mental health centers. There are no items for clinical psychologists in government hospitals that will work alongside the psychiatrists. So even the ratio is not correct. So all of this are actually affecting the distribution of the mental health professionals. Aside from that, we have not tapped other professionals to work into the mental health field. Social work, for example, has a lot of potential kasi sila yung naka-institutionalize. You talk about LCPC, the Local Child Protection Council. You have a social worker there, but you don't have a psychologist there. So there's really no opportunity, even if they want to. We have to have salaries. We have to have regular incomes. Even if they want to, it's like the items, the DBM has to recognize the importance of this personnel, that should actually be included in the staffing. Thank you.
Thank you, Dina. Dr. Ignacio?
Yes, thank you, Dina, for that. I have actually 3 issues here. One is, I think everybody should now be introduced to the Philippine Council for Mental Health, which is your sponsor, the technical committee. I chair the technical committee on capacity building, and Dr. Lim and I are the 2 members of the non-government group, and we're cross-cutting function, and I think we should really hold hands here. This is the reason why my first question was to Dr. Vergara, and the awareness of really the conceptual framework for mental health, which I think everybody should also now be reading about. As an aside, I just want to let you know that at the Philippine Council for Health Research and Development, of which Dr. Antonio and I are members of the Mental Health Research Advisory Group, last Friday, the PCHRD launched a mental health research manual entitled Quality Mental Health Research, Conceptualization, Design, and Methods. And it is being distributed now to all regions through the regional consortia of the Philippine Council for Research and Development. Within that are already the presentation of the mental health law, the implication to the development of the conceptual framework for mental health in the Philippines, which is now an official document, and the conceptual framework goes beyond biomedical orientation, clinical, and it is a biological, psychological, social, and spiritual framework. And it's described there, which has very, very strong implications for research from here on, which in my own reaction to the investment case for WHO, which as a member of the council, we were asked to comment, I really did emphasize that research and development in that investment case must really embrace now the conceptual framework, because it has a lot of implications to how the council and the Department of Health as chair. But the council is members of the council are 6 other different government agencies, and therefore will be involved in all these governance issues. When Dina Nadera is right, there has to be those provision for really budget for mental health in Department of Local Government, Education, Social Welfare, Labor, Commission on Human Rights and Higher Education. That's one. And I look forward to the final report that Dr. Vergara is saying, because I would really be looking at that broader psychosocial conceptual framework for mental health. But I think encourage all of you, 600 participants, to now access the mental health research manual just launched by the PCHRD last Friday, and it's available in its own website. So the framework itself should be guiding us beyond the clinical. I am a clinical psychiatrist. I take on teleconsults. I'm also busy alongside with the rest of my co-psychiatrists into telemedicine, and Dr. Cruz's points here are very well taken. The other reason that I'm wanting to speak, kasi mahaba pa kung ilagay ko sa chat box, is the issue of telepsychiatry. Telepsychiatry has been started by us in 2005, 2006. Dina Nadera was part of this initial efforts when she was with Open University. We proposed that, we have pursued that. We have actually not abandoned that, because at the technical committee for capacity building on mental health of the Philippine Council for Mental Health, this is one of our areas. The World Association for Psychosocial Rehabilitation, which Lucy Lasso is also a member of the Mental Health Research Group, and in the WAPR, and the National Telehealth Center is now in process for my technical committee to develop telemental health modules. This is out of that Infanta project, where we're going to try to develop telemental health in training existing health workers at local government units for the development and the implementation of the aspect of the law. The law provides for the development of mental health services at local level, integrated in the general health care delivery service of rural health workers, And WAPER at this point in time is in fact in a WHO DOH project on community-based mental health project, training barangay health workers, because that's another provision of the law. So we are not talking about us psychiatrists and psychologists just simply available, because the concept of the law now is really the provision of mental health services at local level through local government units, and therefore it's generalist. It is not the specialty-oriented kind of psychiatry. And there it is also in terms of common mental disorders, which include WHO's inclusion of epilepsy. And we are developing telemental health modules with National Telehealth Center, the WAPER, and with the technical committee and capacity building. So the question on how does it reach the rural areas, we hope and pray that the investment case will consider those, because it is not just being absent from work, it is not just being present at work, it is not just dying from mental illness, but it is how much could people really acquire mental health and well-being, and what are the measures for mental health and well-being in those areas, aside from, of course, responding to emergencies, responding to common mental disorders. But even at that area, absenteeism and presenteeism, anxiety and depressions are not quite really the issue, because anxiety and depression at the rural areas, or even epilepsy at the local government areas, take a different picture. So that's why the investment case is a crucial thing for us, especially research and development, which will guide capacity building of local government, of Department of Education, of Social Welfare, of Commission on Human Rights, because Commission on Human Rights is really figuring very well there. So as a summary, please access the Mental Health Research Manual that is not available at PCHRD. You want to know about the conceptual framework on mental health, which is now an official document of the country, as provided for by Resolution 2003, 2020-003 of the Philippine Council for Mental Health. It's written there. The National Mental Health Research Agenda is also in that manual. And we wrote this because we know it's formidable to reach as many people, but there are now 600 so listening to us, the PCHRD using its own infrastructure, and I know that Presi Cuevas has already been aware of this, so DOH will be aware of that, Philippine Council for Mental Health will be aware of that, telepsychiatry, the development of telemental health modules is not just development, it is subjected by the National Telehealth Center to a research component, which we are working out at this point in time, because we will need to know what sort of telemental health training intervention would be effective out there to get the local existing health worker deliver selected mental health conditions at that level of care, meaning it makes the mental health law available, comprehensive, integrated, and accessible beyond the cities and beyond the specialist group. Thank you very much.
Thank you,
Thank you,
Dr.
Dr.
Ignacio.
Ignacio. Yun pong binabanggit ni Dr. Ignacio kanina na manual, I put the link in the chat box for those who are interested to in perusing that particular.
Dr. Antonio is one of the authors in that chapter.
Thank you, ma'am. Over to you, Dr. Jacquina.
Okay. Unfortunately, we have to come to a close, Carl, but there are many, many nice comments on the chat box. I hope the participants were able to read all of them. There are still unanswered questions, but we also still have 2 more lecture series in the next 2 months. So I hope that the audience can log in again on those dates I mentioned earlier. So we'll turn over for our closing back to Mads so that Dr. Canila can give her closing remarks. Summary and closing remarks.
Thank you, Dr. Maligaso and Dr. Antonio for moderating the Q&A session. Well, that concludes the question and answer portion. And we would like to also thank those who have raised their questions, and we hope that we are able to answer some of those queries. We will take note of all of the questions and answered. For those who would like to get the materials and presentations, may we inform everyone that these can be accessed through the link provided in the chat box and also flashed on the screens. And for the post evaluation, we would like to request everyone to please answer the post evaluation, which can be accessed through the link flashed on your screens and also on the chat box. To give us a synthesis of the closing message, let us welcome Dr. Carmelita Canila, Assistant Professor and Chair of the Department of Health Policy and Administration from the UP College of Public Health and co-chair of our Series 3. Dr. Canila, you now have the virtual floor.
Thank you very much, Mads. May I now share my screen? Okay. Yes. Okay. So that's it. Okay. Okay. Good morning to everyone. It has been a morning full of insights, no, and ways to go. I myself, no, was listening intently, no, because my family is of course a user, no, a user of the mental health services of our great leaders, no. Okay, so these are the synthesis. This is the synthesis that I got, no, from I've learned a lot from our speakers, no, and from Dr. Vergara, we learned about the need not to invest in mental health prevention, promotion, and treatment, and of course the direct costs and the staggering indirect costs of the mental health burden, and therefore there's a need for us to really look at the different tools by which we can use to analyze now our burden of mental health diseases, and advocate for policymakers, for decision makers to pour in more investments in mental health programs and services. So therefore, there's a need for us to really look at the extensive services that need to happen. And from Mayor Treñas, he provided us an insight on what's happening in Iloilo at the LGU level, and he made a very valid, very strong point on capitalizing social inputs, social infrastructures at the local level, and the need, no, for holistic intervention, especially now with the COVID-19 pandemic still ravaging, no, the country. And of course, he shows a valid example of championing from creating the law to implementing the mental health law at the LGU level, and the need for partnering with local and national or organizations to collaborate with one another to innovate, no, to innovate interventions that nourish the physical, physiological, and psychological well-being. And he mentioned different innovations like art in the park, communal work, and the need not to develop or to enhance one another's life, to aspire for dreams, no, to enhance oneself, no, and to learn from one another. In terms of the digital technology in mental health care, that was a very extensive input on people engaging with technology, especially with the recent or the young generation. and how can we make use of the effective and the safe digital interventions, no? And it provides opportunities for universal health care, to form support groups and to serve more people, especially in hard to reach areas. And however, there is also a need for us to look for to ensure, no, to ensure that the technology and the future of mental health treatment will be convenient enough for people, that we need to ensure there's anonymity, and it can also, while providing the pathway for continuity of care and providing lower cost, it should also provide a 24-hour service, and instilling interests among among people with different interests in life, and ensure that there's consistency of services being provided. However, there is also a need for us to ensure that the technology will be used in complementarily with the traditional service provision, and to protect, no, the confidentiality, while ensuring that we have the objective data collection. It has to confirm or to conform with the Data Privacy Act. So, okay, and in mental health research, Dr. Torres gave us an insight, no, of the mental health research being underfunded, being underprioritized, and the need, no, for the ethical guidance and issues about placebo use or research results using placebo, and ensure that this research ethics and the competencies to do research can be done or should be done with improving the competencies by training and sharing this with the academic community. So in summary, our competent speakers provided us an insight on how to move forward. One is the key recommendations for leadership, governance, population-based mental health interventions, in line or in consonance with the UHC, building the capacities of local and communities and LGUs, and do research and development, and also provide ways and means not to innovate and give access to mental health services in primary healthcare facilities, and the need to evaluate technologies or the use of technology in mental health regarding effectiveness, compliance to the Data Privacy Act, regarding guidance and regulating, and the different platforms by which we can regulate this different technology so that they can be used effectively, and definitely assurance for ethics in mental health research. Now, in the questions and answer portions, there are very relevant questions, and were valiantly answered by our competent speakers and panelists as well, that in doing ethical research, the research design must be robust, and the methodology shall also include providing the referral pathways, that there is a platform and a robust system for protecting data validity and data privacy, that we need to ensure the competencies of the research team, and therefore the need to cascade this to schools, share this with the academic community, and build the capacity of the academic community to do research. There's also a call for mental health package within the context of the UHC, and the focus on evidence of the use of evidence of costing studies for promotion and prevention interventions, the use of technology, social media in mental health. However, there is a comment about addressing inequity for communities with no access to the digital world, and the inclusion of family support, no, in the digital or in the provision of mental health services by digital means. And there was also an issue that was raised about the distribution of providers for mental health services. However, there was a strong call no, for provision of mental health services in barangays at the local primary health care. And this makes a strong case for investment. So there's also a need no, to ensure that this becomes a reality, and for us, for everyone among us, to really understand, to internalize the conceptual framework for mental health and the national mental health research agenda, and the call for us to participate in making this a reality. So I think that was my last slide. I really thank everyone. So we have more than 600 participants, and now it's down to 570. My prayers for all of us not to be safe and well in this time of full of challenges. And as Mayor Treñas has said, for us not to reclaim again our sense of oneness, our sense of well-being, and our capacity to dream again and make these dreams a reality, despite all the challenges amidst us through our environment. So I now give you back to Sir Mads, and I thank you all for giving me this opportunity to participate in this very important, very timely, very relevant undertaking, and we hope to see all of you again in the next series. Back to you, Mads.
Thank you very much, Dr. Canila. And also thank you for everyone who has joined us for the Series 3 of our summit. To our dear speakers and panelists, our gratitude goes out to all of you for sharing your time and expertise with us. To all of our participants, thank you very much for your participation. We hope to see you again in our next series. So that's about it for Series 3 of our summit. We hope that it has been a productive knowledge sharing for every one of us. On behalf of the Mental Health Division and also the entire team behind the summit, again, we thank you everyone for joining this summit. The next schedules of the series are flashed on the screens for reference. And thank you.
Mads, walang picture taking yung mga speakers?
Not yet, ma'am. Let me just check. Sorry, Sir Marlon, someone is asking for the evaluation form. Can it be placed again yung link po sa chat? Thank you.
Di ba kanina may photo op kasi hindi alam nung audience na yung photo op sa organizing eh. Kasi may nagtatanong na hindi daw nila maon ang camera. Ni Marlon hindi kaya, di ba? Yung malaking grupo ng picture taking. So yung organizing and speakers lang.
Off na tayo, hindi pa?
Pero kanina sila nung nag-photo op.
Ma'am, Carmi po ito. Meron po bang parang anong tawag nyo doon? Evaluation natin o anong tawag? Hindi postmortem, pangit ang postmortem. Parang lessons learned.
Pero
Opo.
may evaluation silang pinilapan pero walang for individual speakers.
Opo. Yung sa atin po. Yung sa atin po, wala po tayong lessons learned. Pagbabalik tanaw po sa series natin ngayon.
Merong pag may meeting ang committee sa Tuesday, usually pino-postmortem yung meeting. Yung feedback, oo.
Thank you po.
Sa evaluation, Carmi, nasa evaluation sheet din kung ano yung mga lessons learned.
Sige po. Opo.
Hindi. Yung padala sa'yo pag kapag na-collate na, pinipresent yun sa committee.
So ma'am, isasama sila sa committee meeting, next committee meeting para makita nila?
Pwede. They can join us. Oo. We can invite them para makita. Kasi hindi nga postmortem. Ini-evaluate natin lahat ng kung ano yung mga, kung may glitches, kung there are things we need to improve, yung mga ganon. Pati yung pag ng attendees and all that.
Si Mayor Treñas pala ma'am, author ng Mental Health Act.
Alin?
Si Mayor Treñas.
Ano siya?
One of the authors of the Mental Health Act.
Ganun nga. Yun na nga, hindi ko alam yun eh.
Marami sila actually sa Congress at saka sa
Congress. Kasi ang kabisado ko kasing parte yung doon sa Senate eh. Kasi maraming mga bills yan bago finally na-collapse into RA 11036 eh. Ang daming mga bills na pinut together eh. Yung original kasi sa Congress, maraming version din yan eh. Kasi may mga version na